When a patient is rushed through the automatic double doors of an emergency room, time isn't just money, time is tissue. In no department is this absolute truth truer than in radiology. If a patient presents with sudden weakness on one side of their body, slurred speech, or a drooping face, every single tick of the clock signifies the death of millions of brain cells. This is a stroke. But before an emergency physician can administer a powerful, clot-busting drug like a tissue plasminogen activator, they face a dangerous clinical crossroads. They have to know exactly what kind of stroke they are dealing with. Is it an ischemic stroke, caused by a blocked artery that needs to be dissolved? Or is it a hemorrhagic stroke, caused by an active brain bleed where clot busters would be instantly fatal? To find out, the patient is thrown directly into a CT scanner. But here is the logistical bottleneck that has plagued modern medicine for generations. The scan itself takes less than a minute, but waiting for a human radiologist to open the file, read the images, and write the report can take precious half hours. Today, AI is rewriting that timeline. In a traditional hospital workflow, diagnostic images operate on a first-come, first-served basis, or are manually triaged by an ER doctor calling down to the basement reading room. If a radiologist is currently parsing a complex 500-image spinal scan from an outpatient who broke a bone 3 days ago, a critical stroke scan might sit in a digital waiting line for 15 or 20 minutes. Modern deep learning algorithms have completely transformed this sequence by sitting directly on top of the imaging highway. The moment the CT scanner finishes capturing the raw spatial data of a patient's brain, the DICOM imaging files are instantly duplicated and routed to an AI triage model running on local hospital servers. The algorithm doesn't look at the image the way a human does, admiring the anatomy. It processes the pixels as a massive mathematical array, searching for subtle, hyperdense or hypodense clusters of pixels that signify pooling blood or a sudden lack of perfusion. The AI doesn't replace the final diagnosis of the radiologist, instead, it acts as an intelligent traffic controller. If the machine detects an anomaly representing an acute brain bleed, a massive pulmonary embolism in a chest scan, or a collapsed lung on a routine X-ray, it automatically intervenes in the workflow. It takes that specific patient's file and physically bumps it to the absolute top of the radiologist's reading queue. It triggers a high-priority, glowing red notification on their workstation, effectively whispering in their ear, "Stop what you are doing right now, look at screen 4, room 3's scan is a life-threatening emergency." What used to take an average of 45 minutes from scan completion to specialist review is now being completed in under 4 minutes. In the world of stroke neurology, where it is estimated that a patient loses nearly 2 million neurons every single minute a major vessel is blocked, this structural acceleration is the difference between a patient walking out of the hospital or facing permanent, life-altering paralysis. But let's look below the surface here, because this development brings up a deeply fascinating technical concept known as pixel-level pattern recognition. Human eyes, no matter how elite, are fundamentally limited by our biology. A radiologist who has been awake for 14 hours straight on a grueling night shift might suffer from what is known as perception fatigue. They are looking at thousands of shades of gray across thousands of images every single day. An AI algorithm, however, never blinks, never gets tired, and doesn't drink coffee. It can calculate variations in pixel contrast that are completely invisible to the naked human eye. It can cross-reference the geometric density of an internal structure against a training library of millions of previous historical scans from patients all over the globe in a fraction of a second. Yet, this power creates a profound cultural shift in our hospitals. Some critics ask, if the machine is this fast and this accurate, are we on the verge of phasing out human radiologists altogether? If you talk to the engineers writing the code and the physicians using the tools, the answer is a resounding no. The true power manifests when the machine handles the mechanical sorting, allowing the human to focus entirely on the highly nuanced, deeply clinical interpretation of complex, edge-case pathology. It's an alliance, not a replacement. If you walk into any modern hospital today and ask a physician or a nurse what the hardest, most exhausting part of their job is, they won't tell you it's the blood, the trauma, or the difficult diagnoses. They will tell you it's the computer. For every single hour a doctor spends looking at a living, breathing patient at the bedside, they spend an average of 2 additional hours staring at a monitor, typing, clicking through drop-down menus, and filling out incredibly rigid templates within the electronic health record, or EHR. We are living through an unprecedented epidemic of healthcare burnout. Excellent, deeply compassionate clinicians are walking away from the medical profession in record numbers because they feel they've been turned into glorified data entry clerks. The administrative burden is actively crushing the soul of medicine. But an advanced branch of artificial intelligence known as large language models and ambient voice technology is staging a massive rescue operation. This is the reality of ambient clinical intelligence. When a doctor enters an inpatient room, they simply ask the patient for permission to activate an AI-powered listening device. Once approved, the smartphone or a specialized wall-mounted microphone array begins capturing the natural audio stream of the conversation. The doctor doesn't have to alter their speech pattern, use robotic keywords, or speak commands to the device. They can talk to the patient like a human being, asking about their pain levels, listening to their concerns about their medication side effects, discussing the plan for their discharge, and joking about the terrible quality of the hospital food. As the raw audio waves flow into the secure, HIPAA-compliant cloud server, an array of specialized natural language processing algorithms goes to work. First, advanced speaker diarization filters separate the voice of the doctor from the voice of the patient, the spouse sitting in the corner chair, and the background hum of the room's air conditioner. Next, a highly trained medical language model translates the casual conversation into formal, highly structured medical prose. Imagine a patient saying, "Yeah, my chest felt like an elephant was sitting on it yesterday, but today it's just a dull ache right here." The AI automatically formats this for the EHR note as, "Patient reports history of severe substernal chest pressure yesterday, currently downgraded to mild localized dull pain." The algorithm doesn't just transcribe the words verbatim, it understands clinical intent. It filters out the social chatter about the weather or local sports teams, focusing exclusively on the clinically relevant information. It groups symptoms logically, maps out the reported timelines, notes the patient's current subjective pain scale, and isolates the specific changes the doctor mentions making to the medication regimen. By the time the doctor leaves the room and walks back to the nursing station, a perfectly structured, comprehensive clinical note is already sitting in their draft folder inside the electronic health record system, awaiting their final review, modification, and digital signature. Think about the monumental psychological shift this creates in a hospital room. When a doctor is forced to type on a computer while talking to a patient, they are physically turned away from them. They are missing subtle, critical visual cues, the micro-expression of fear when a certain diagnosis is mentioned, the slight wince of physical discomfort when a patient shifts their weight, or the hesitant pause that means the patient doesn't actually understand the complex instructions they are being given. Ambient AI completely restores eye contact to medicine. It allows the physician to pull up a chair, sit down, look the patient in the face, and truly listen, knowing that the machine is taking flawless notes in the background. But the administrative utility doesn't stop at note-taking. These models are also being trained to cross-reference these real-time notes with the hospital's complex medical coding and billing architectures. They can instantly flag if a document is missing a specific clinical justification required by an insurance company, dramatically reducing the weeks of back-and-forth paperwork that frequently delays a patient's discharge or stalls their access to vital home healthcare services. It is a profound realization that some of the most life-saving work AI is doing inside hospitals has nothing to do with complex robotic surgeries, but rather with liberating the human mind from bureaucratic gridlock. As we look deeper into this transformation, we must recognize that administrative AI extends far beyond the documentation of a single patient encounter. It is fundamentally reshaping the macro-level logistics of how a hospital floor operates on a minute-by-minute basis. Consider the highly complex, high-stakes puzzle of bed management. On any given day, an urban medical center functions like an overbooked airport. There are patients backing up in the emergency department waiting for an open room upstairs, there are patients in the recovery room waiting for an intensive care bed to become available, and there are inpatients whose discharge processes are stalled due to delayed pharmacy deliveries or transport delays. When human staff try to manage this chaos manually, using dry erase whiteboards and frantic phone calls, the system inevitably experiences severe gridlock. AI-driven operational intelligence systems change this dynamic by treating the entire hospital as a living, fluid network of data. These systems analyze years of historical admission patterns, current local weather anomalies, regional viral outbreak data, and the precise, real-time status of every active chart in the building. By doing so, the algorithm can predict with startling accuracy exactly how many emergency admissions will occur on a rainy Friday night, and precisely which inpatients are mathematically most likely to be cleared for discharge before noon. This predictive insight allows nursing supervisors to pre-allocate staffing resources, prepare specific specialized wings ahead of time, and dramatically shorten the hours that vulnerable patients spend lying on hard stretchers in noisy hallways waiting for a room. Furthermore, this automated operational oversight plays a critical role in pharmacy logistics and medication safety. Inside an inpatient unit, the distribution of high-risk medications requires rigorous double checks to prevent catastrophic errors. AI systems embedded within automated dispensing cabinets use machine learning to track normal prescription patterns for specific diagnoses. If a clinician accidentally enters an incorrect dosage value or requests a medication that has an unflagged, highly dangerous interaction profile with a drug the patient was prescribed by a different specialist 3 days prior, the system goes beyond a generic warning pop-up. It actively analyzes the patient's comprehensive clinical profile, cross-references recent lab metrics like kidney and liver function, and provides a contextual, intelligent block on the medication release. By functioning as an automated, highly precise layer of institutional armor, the technology intercepts potential human errors long before a syringe or a pill ever reaches the bedside. This allows clinical teams to operate with a profound new layer of psychological safety, knowing that the structural complexity of modern multidrug therapies is being monitored by a system that possesses total, unblinking institutional memory. As we witness these invisible structural changes, it becomes undeniably clear that the integration of artificial intelligence into the administrative and logistical fabric of healthcare is not merely a convenience. It is a fundamental, non-negotiable upgrade to the safety, efficiency, and humanity of the entire inpatient experience, turning chaotic institutions. Hyper-connected clinical landscape, we must confront the ethical fault lines and legal paradoxes that emerge when machines begin making high-stakes choices. If an AI system flags a patient for an early intervention, and a doctor chooses to override that recommendation because their intuition suggests a different path, who is held accountable if the patient deteriorates? Conversely, if a doctor blindly follows an algorithmic prompt that turns out to be based on corrupted or biased historical data, where does the malpractice liability fall? Is it the fault of the practicing physician, the hospital administration that procured the software, or the corporate engineers who designed the machine learning model? These are not hypothetical legal puzzles, they are active battles being waged in regulatory chambers and courtrooms right now. The core issue resides within what computer scientists call the black box problem. Unlike traditional rule-based software where a human can trace every single line of logical code, advanced deep learning models function by adjusting hundreds of millions of statistical weights across vast neural networks. The AI can provide an incredibly accurate prediction, but it cannot definitively explain the underlying clinical rationale behind its conclusion. It cannot tell a physician exactly why it weighted a minor shift in respiratory rate higher than a major shift in blood pressure for a specific patient. This lack of explicit transparency forces human clinicians into a deeply uncomfortable dynamic of blind digital trust, fundamentally altering the traditional architecture of medical decision-making. Furthermore, the integrity of these models is profoundly constrained by the historical datasets used to train them. If an algorithm is trained primarily on clinical trial data from affluent, urban academic medical centers, its predictive parameters will naturally reflect the demographic profiles and resource access of those specific populations. When that same model is deployed in an underfunded rural community hospital or an ethnically diverse public health facility, its diagnostic accuracy can drop precipitously, leading to a dangerous phenomenon known as algorithmic bias. The machine may fail to catch early signs of deterioration in marginalized patient groups simply because those specific physiological signatures were underrepresented in its initial training pool. To prevent these digital safety systemic failures, modern medical networks are establishing strict frameworks of human-in-the-loop oversight. These guidelines assert that artificial intelligence must strictly operate as a decision support utility rather than an autonomous clinical authority. The machine is there to surface hidden patterns, automate repetitive data sorting, and issue defensive alerts, but the ultimate diagnostic interpretation, the final therapeutic choice, and the vital delivery of human empathy must forever remain anchored to the hands of a qualified clinician. It is a profound realization that the ultimate success of artificial intelligence inside our hospitals will not be measured by the raw speed of its processing chips or the complexity of its neural architecture, but by how effectively it serves to enhance, protect, and empower the timeless bond between a physician and a patient. Audio is 50% of the viewing experience. If your video sounds echoing or has background hiss, people will click away instantly. Click on your main audio track, and look at the top right panel under Audio. Look at this feature right here, Enhance Voice. Turn this on, adjust the slider, and watch how CapCut's background AI strips away room echo and PC fan noise instantly. Next, look at your decibel meter. You want your main talking voice to hover safely between -6 and -12 decibels. If it hits the red zone at 0, your audio will distort, and your viewer's ears will bleed. Use the volume slider to level it out. Now let's add some flavor. CapCut has a massive built-in library of copyright-free music and sound effects. Go to the top left, click Audio, and search for whoosh. When you introduce a text graphic or a transition, a subtle whoosh sound effect tricks the viewer's brain into finding the movement satisfying. For background music, remember the golden rule: keep it low. Background music should typically sit around -20 to -25 decibels so it doesn't fight with your voice. Let's apply a quick fade out at the end of the clip so the music doesn't abruptly stop.